And next case is presented by the Associated Professor Direk Tantigate. He will show us about the case in the gradual correction topic.
Good morning. Thanks for having me here. So this case, some of you might haven't seen this case before. So this case is 26 male, came with me, present with a deformity and limping for 5 years after injuries. So this is the clinical of his leg, look like, and this is he's like walking with limping. So he got a bad scar at the right leg, at the distal leg. So this is what he got from his injuries: open fractures of right distal tibia, type T3, complete tear of anterior and posterior tibial arteries, and repair popliteal artery to posterior tibial artery by graft bypass. So and has a couple time to revise the graft, and also have a common peroneal nerve palsy, but now still recover, and multiple debridement, and he got skin grafting. His background is smoker, and occupation is erections. Motivation is strong, but compliance is just fair, and family support is good. He comes with his wife every time. So the physical examination revealed the skin graft and a varus deformity at about 12 degrees, shortening for 4 centimeters. The leg length is discrepancy for 4 centimeters. The motion is fine, but the ankle is stiff in equinus. And the function of peroneal nerve is still recovered. Now there is a callus at the lateral side of the foot. So the vascular examination revealed the diminished pulse at the right popliteal arteries and dorsal pedis and posterior tibial artery, just only the Doppler. So this is his X-rays. He got a plate on the distal tibia, but not that great. The mechanical axis is deviation to the varus. So, and the leg length discrepancy about 4 centimeters. So I use the clinical examination to determine the rotational malalignment by using the rotational profile. So you can see the internal rotations of the leg. And the colonal plane analysis this is a mechanical axis of the tibia. It's varus about 12 degrees. And the joint line, the mechanical axis according to joint line is translation about 21 millimeters. And the sagittal plane is revealed anterior angulation about 14 degrees. So the rotational, internal rotation about 5 degrees, shortening about 4 centimeters on the axial plane. So this is the overall deformity analysis. And shall we proceed to the end of the case, or just stop by to do the, have your comment first?
Maybe we have a short discussion and then we can see. Okay. อันนี้ไหมหรือมานั่งตรงนี้เลยก็ได้นะครับ1 2 3
Hello. Okay. We should start with the deformity analysis again. I think all the deformity have analyzed now. Our concern in this case is first is a soft tissue on the anteromedial aspect of the leg, which we don't want to do any deformity corrections or osteotomy in that area because of they have the poor biologies. My second concern is the history of the vascular injuries. If we need to do any acute corrections in order to regain the length, I will not do that, because it may create some stretching of the vascular and have some risk of the blood supply to the distal part. I think about if we have to do acute correction, we will do shortening, acute shortening. in order not to take any risk of the vascular. But the best way to correct is maybe gradual and should be a bit above the injury zones. At least the vascular in that area should be okay. Yeah, just my concern. And yeah, many ways to Rome. If you want to correct everything at the same in the one operation, you just do the gradual correction with the hex support.
I agree with Dr. Chitwi with the gradual correction with hex support, but another concern for me, when the patient have a long time of the limb shortening, and they usually have the fixed or rigid equinus deformity, and it will increase when you lengthening that limb. Many times, aside from the ring fixator, I usually add the ring to the foot to prevent the more flexion deformity of ankle.
Can go back to the pictures, the clinical pictures. Yeah, okay. Yeah, if you look, the anterior soft tissue, it's really terrible. You see the tibialis anterior tendon adhere to the skin. That means it's very hard to do any surgery down there. Yeah, but fortunately, if you look at the deformity, it's quite high. Yeah, it's quite high. That means we can do the correction at the core of this deformity. Yeah. If you look at the posterior soft tissue, I think it's quite good. That means I do the simple thing. I just make the osteotomy correction I approach by the posterior medial and fix with the plate. Yeah, because the soft tissue at that area is good. Correct all deformities. Make a cross-wedge osteotomy and then let the bone heal. Or wait, you can wait. After you correct the length, the rotation is good, the angulation, angular deformity is correct. Yeah, cut the fibula and then make a straight tibia. Now it's easy. Then you can make a lengthening up at the proximal tibia. That's easy one. Right? That's for my... So.
Are you going to remove the plate?
Yes, yes.
Which approach? The plate is pressed and the anterolateral approach.
Yeah, you can make an anterolateral on the fibula, quite more lateral to remove screws. And one screws you can remove from the medial percutaneous. Yeah, and then remove 3 screws at that area. Yeah, I think we have to remove the distal. Otherwise, it's very difficult to correct because you have the plate over there.
So shall we proceed to? So this case, I thanks for all comment. I concern everything that our panelists comment. So I set a goal with the patients. First, correct deformities, stable constructs, functional restoration of limb, and last but not least, minimize complications that might occur. So the technical consideration, what I think, the locking plate, I think about the blocking or damaged screw hole, damage of the hex socket, and concerned about the osteotomy size, I will do the slow osteotomy by using a drill or like a jigsaw to put the frame assemblies and also make up good prescriptions, subsequent internal fixation, and subsequent soft tissue collection at the end of the collection of the bone. So discuss about the possible complication. First, the skin complication might be taken into account. The vascular compromise, I usually prep leg of the patient to the toes to make sure that I can feel the pulse or I can evaluate the pulse all the time that I move the bone. So, and concerned about the nerve injury, not the peroneal nerve and also the superficial nerve, and make a neuropathic pain to interfere with the quality of life. And also discussed about the non-union at the osteotomy size and residual deformity, might be like some residual leg length discrepancy. So this is what I did. I put the flame, I removed the plate, try to protect the soft tissue, and do some acute collection as much as I can without compromise the vascular. So, and this is a sagittal view. So what we got is better alignment, but not great, and still have a leg length discrepancies without compromise the blood supply. So I collect the translation first to make sure that the skin is okay, and I do the angulations, anterior angulation later by gradual collections. The system I use a Taylor special frames. This is 4 weeks out after initial operations. So this is 7 weeks after the operations, 9 weeks, and then 14 weeks. So actually, the patient would put his weight on it without concerning the loose of the screw. So there is some like a contract and shortening again. So I recommend him to do the subsequent plate fixations or internal fixation, either nail or plate. So he preferred not to. So he says thanks, but I still happy with that. So 6 months after injury, I take it out, and there is equinus deformity, 15 degrees. So our toes flex more when the ankle does it flex. So I do the implants and do the soft tissue collections. So this is 1 year, and this is 1.5 years. So patient doing well, but they seem still not that what I expect. I expect more length, but the shortening between the consolidations, it might a little bit shorter. So this is the final film, and the callus is gone after he Tantigate his foot and do the collection of the alignment. So this is compare between two sides. Thanks. So that's all my case.
Thank you very much. Congratulations. I would like to raise some things for you who are going to be the deformity correction surgeons or something. You can notice that the rotational deformity, there are two ways, something like physical examination by eyes, right? And CT scan. So when you set the scanogram to patella center and you see something wrong, and then if you like to evaluate, it is kind of eyeball, right? Do you agree? It is eyeball assessment or CT scan. Let's see. Okay. The other point is what you have to think about is gradual or acute correction. There are two ways, right? But if you have soft tissue complications, I will just emphasize to you, ring fixator seems like very clumsy, but it is minimal invasive way to do very complicated things. You have antriangulation, you have valgus or translation, and then you have rotational. So that is a minimal invasive way. But it doesn't mean if you don't have the hex support, you cannot do anything. You can do conventional way, right? But you have to change the hint from time to time and operate time. And then it is now that we accept to combine plate or nail, even in one operation, or you can do conversion later on. And in this case, the patient, I think it is very rare that the patient loves the ring.
Because that time is a COVID situation.
Oh,
he opted not to go to hospital.
Oh, okay.
To save for his life.
Because the problem of the ring is the patient try to say, oh, please remove the ring as soon as possible. But this is, he loved the ring now because of the COVID. Okay. Thank you very much. Any comment from the floor or any question? We still have 2 minutes for this case.
Just ask the audience in this room, how many of you cannot do the ring fixator? Raise your hand up. Cannot. Cannot. Okay, I raise my 2 hands. I cannot do it. That's why I try to make a simple thing. I can do just the simple distraction in one frame. That's for me. Yeah, but if you have the one can do the ring fixator, that's another option. Yeah.
So that's why we have a Thai limb lengthening, reconstruction, surgery, AATLRS. No, we have a line group. And if you are interested in this, we can join and then we can have it in the next year. We talk a little bit about this more. So there are many options, right?
Let me add some questions. How many of you cannot put K-wire in the bone? How many of you cannot put K-wire in the bone?
Cannot.
No, cannot. No, everything can put a K-wire in the bone. How many of you cannot put a chance pin in the bone? No.
I can.
How many of you cannot tie the bolt? No.
I can.
It's easy, but it needs some understanding. Thanks.
Okay. Let's learn something new, right? Okay, I will learn.
I will say that, you know, for conventional ring, it is a little bit difficult. For the hex support, it is for the resident. As long as you fix the ring in the proximal and distal. And the other thing is the computer will work. Seems to be interesting, right? It doesn't mean I'm promoting the hex support, but this, you know, this is 23, right? And then we have to know the option, as Ajahn Siriraj said, as many of our panelists said.